Thank you for downloading Children's Pedcast. I'm Jimmy Bellamy, and this week my guest is Dr. Rachel Miller. Dr. Miller is one of 2 pediatric gynecologists at children's hospitals and clinics of Minnesota, and they are the only 2 in the state of Minnesota. Dr. Miller talks about the importance of sending your child to a pediatric gynecologist and the differences between that and sending them to your gynecologist or one who sees adults exclusively. And she's also on Twitter. You can find her at teen, GYNEMN. And you can find us on Twitter at childrensmn. You can also find us on the web at childrensmn.org. And you can download our show on iTunes, rate, review, and subscribe. You can find us on Podbean and Stitcher as well. Dr. Miller is seeing patients in our clinics in Minneapolis, St. Paul, Woodbury, and Minnetonka. So here we go. Episode about pediatric gynecology with Dr. Rachel Miller. No, and that's totally fine. We'll just get right into it. Now, what's the official title? And that's one thing I struggle with here sometimes, is that there are so many different programs and so many different titles that I sometimes just call something by a title that isn't its formal title. What is the formal title in your program?
Pediatric and adolescent gynecology.
Okay. And you have been with Children's for how long?
Since 2008.
Okay. 7 years. Has it flown by? Has it?
Absolutely flown by. Yeah.
And where were you prior to that?
Completing my fellowship at Cincinnati Children's Hospital in Cincinnati, Ohio.
And where are you from originally? I'm just curious.
Yep, I grew up in Fargo. Fargo,
North Dakota? All right. I worked for a newspaper in a prior life, and Forum Communications owned us.
Yeah.
Still owns the paper in Duluth where I worked, and I made a few trips to Fargo for training and meeting people and everything.
Yeah, it's changed quite a lot.
It has.
Since I finished high school anyway.
The downtown area is pretty cool. I like it.
As evidenced on the ESPN game day twice now.
Yes, well, they love their Bison. That crowd. They're kind of like Packer fans for college football.
Yeah.
And I mean that with respect to both Packer fans and Bison fans.
Yeah, I think that's probably a fair comparison. I've never been to a game in the Fargo Dome. You know, when I lived there, it was still at the outdoor freezing cold stadium. But my understanding is that it's just deafening inside that dome. And
I think they've won 4 straight championships.
Yeah.
And the startling stat I saw was that, and I know you guys aren't listening to a football podcast, I promise. We'll get to the topic at hand. But the alarming stat, in a good way, was the seniors on this year's team have won more national titles than games lost. Because they had 4 national titles in their time there, and I think they had like 2 or 3 losses in 4 years.
Yeah, I haven't seen that one. That's amazing.
There you go.
That's amazing.
But you're here now. You're in Minneapolis, St. Paul. And you are one of only 2 pediatric gynecologists in this great state, correct?
That is correct.
So tell me about the work you do. And I've had this question posed to me because working in communications and working with a variety of programs, we often get the question, why would I come to Children's? We get a lot of people who think that we are here to help kids who have cancer. We're here for giant traumatic injuries or ailments, but we don't do, like some people say, well, we don't want to bother you with the little things. And really, we do everything here. So in this case, why would somebody go to a pediatric gynecologist as opposed to their parents' gynecologist?
I think it probably varies a little bit by the individual, but most people who completed a general obstetrics and gynecology residency had few, if any, interactions, particularly with children and even young adolescents, with the exception of maybe in the obstetric realm. But they really didn't likely see many in a purely gynecologic standpoint, unless they're a resident who rotated with me here. But even then, it's still for fairly limited exposure. And so, what most, I think clinicians sort of now recognizes that there's fairly limited reproductive health in a general pediatrics residency, and likewise in a general obstetrics and gynecology training program. And so somewhere there's a population that seems a little bit lost, which is why I think specialists like adolescent medicine, which is a subspecialty from pediatrics, and then increasingly pediatric and adolescent gynecology, which is a subspecialty off of obstetrics and gynecology, because there's problems that are unique to children and particularly younger adolescents, that you can't just treat them like a slightly smaller adult, or likewise like a slightly larger child. So there's a little bit of a knowledge base that's sort of unique to that specialty. And then too, some of it is the difference of coming to a center for children and adolescents versus walking into your mother's obstetrician's office where there's a bunch of pregnant women in the office and you're 9 years old, and they don't have a blood pressure cuff that fits you, and they don't really know how to interact with you or provide sort of that more pediatric patient-centered, family-centered care. Although I have no doubt that everyone tries very hard, but in the end, you don't know what you don't know, and so you want to ideally go somewhere where that's what we do day in and day out all the time. We've got a bunch of tricks up our sleeves for making the whole conversation, the exam is very child friendly, and with the hopes then that they have a really positive initial reproductive health visit.
There are a lot of elements that you mentioned that I think often do get overlooked when talking about caring for a child. There may be situations where families think, let's just get in and get it over with. And there are things that either don't put a child at ease or could heighten their concern or their trepidation. And I do think it's important to be able to go to a place where it caters to you as the individual, as the child in these cases, and hopefully make the visit more pleasant, or, as I like to say sometimes, less traumatic. It's like bringing, I don't know, whether it's a dental visit or any kind of doctor visit, or even if you're bringing a pet to the vet, people always talk about, here are some strategies to make it easier. Mm-hmm. That I assume, and please tell me if I'm right or wrong, that these visits often are much, much easier than an experience at a big person doctor.
Yeah, I think what's been really interesting is sometimes their mother or female caregiver has really prepared them for an adult pelvic exam. So a lot of kids come in and they're pretty freaked out, sort of expecting that. So one of the things that we do is we try to lay out kind of in a new patient welcome letter, these are kinds of things you might expect, but also, on our website, we have sort of, we try to lay out sort of an idea of what you might expect. And then at the visit, try to kind of lay out how this visit's going to go. And, this is kind of, usually with younger kids, I'll start talking to them first and just ask them simple questions like, what do you like to do for fun? Who lives with you? What school do you go to? What grade are you? Things that they absolutely know the answers to. They're simple questions, and they're pretty comfortable answering, even if they're little. And sometimes you get some wild answers, and you just kind of roll with it. And then I like to make sure that patients have an idea of why they're here, because I don't think it's fair to the kid to be brought to a clinic of my specialty and have no idea why they're there, mm-hmm. Because they need to have some idea.
Yeah.
And the answers that you get from these kids are really funny sometimes. Just, the terms that their family uses or the language or whatever. And I like to quote them directly because I think, it makes it memorable. And it just gives you an idea too of where they're at with what's going on. Whether it's something that's sort of fairly comfortable in the family or whether it's something, that they're really uncomfortable with, because that's really reflected in how the child responds to that sort of just simple, what brought you in today? My favorite answer being my mother's car.
The literal answer.
Very literal answer. But I think too, we are allowed more time than in an adult practice, which is really critical, particularly when you're seeing adolescents, because they deserve some of that visit to be done by themselves, and, collecting portions of the history maybe that they would prefer to keep to themselves, that their parent not know sometimes. And sometimes it's just a little thing, like I tried one puff of a cigarette, but by building that rapport of, okay, and what'd you think? I mean, just sort of what'd you think about that? And something, and I'm not going to tell your mom that.
Yeah.
Then over time, should something that's a bigger deal come up, they know that you're not going to be necessarily disclosing that to their parent.
Because that trust has been established.
Because that trust has been established, yeah. Of course, the exception being really serious, life-threatening things and stuff. But, everyone who makes recommendations recommends that you talk to adolescents, at least briefly by themselves so that you can hopefully help them evolve into being an advocate for their own health as time goes on, because eventually they will have to be.
Because people's comfort levels can be different, or their families may handle things differently. How do you navigate the visits themselves? Are parents present for it? Are they present for a portion? Are they not present at all? And then are you met with any resistance once a family is there, or is the fact that they've already walked through the door mean that all of that resistance has subsided?
Yeah, usually with adolescents, our sort of clinic procedure, which is outlined for them in a welcome letter that they receive at home prior to arriving at the clinic, outlines that, of course, we're going to talk to the entire family and gather as much background on their current complaint, as well as their past medical and surgical history and family history. But that then a portion of the visit, we do intend to talk to their adolescent by themselves for a few minutes. Ideally, sort of the clinic layout then is that we talk to everybody all together, and hopefully I've already received some records from their referring clinician or primary care clinician as well. So I have some background from their perspective too. And then ideally I can excuse the adolescent and actually talk to the parent alone for a couple minutes too, because that gives them an opportunity to voice any additional concerns that they have that they may not want to share in front of the actual patient. And and then we just kind of switch them out and send their parent out of the room, and then bring the adolescent in and review some of those topics that many would prefer to keep more private, and then proceed with whatever exam we think is indicated. And what's really surprising, I think, to a lot of adult women is that I don't actually do a lot of complete pelvic exams like they're used to getting annually at the office, because there's just not very many indications for that, particularly in young adolescents and definitely children. And if we think something like that is really necessary, the advantage of working somewhere like Children's is they have so many options for sedation. I can do laughing gas. I can do conscious sedation. We can even go to the operating room if we have to, if we really think a complete exam is warranted. And then too, our imaging here at Children's with the radiologists, a pelvic exam at Children's is over your tummy, whereas a pelvic exam at every other hospital in the city means a transvaginal ultrasound. Whereas if I want a transvaginal ultrasound at Children's, I have to order that specifically. And so everything just has a little bit of a different meaning when you're working with kids and teens. And then with the exam, I always offer who they would prefer to chaperone. Do they want their parent back in the room, and that's fine? Or would they rather have one of the clinical assistants or medical assistants? And then once we complete the exam, let everybody get dressed, because we try not to talk to people half naked.
Yeah.
Yeah.
That's a policy I have as well.
It's a good one. And two, I've really made an effort to make sure we don't have paper gowns, and we don't have paper sheets. Everything is cloth. It's, soft, and nothing feels, hopefully as uncomfortable as it can be.
Yeah.
And regroup with the family and just kind of review what we found, what kind of, do we think any more further evaluation is needed? What are their treatment options? And then, if we think some follow-up is necessary, or can they return to their primary doctor?
What are some cases, if any, where people are coming in annually?
So typically, if I'm prescribing a medication, then I like to see them at least once a year, so I know if there's been any interval health changes, or someone else has prescribed them a medication that then makes my medication either unsafe or contraindicated, or not working as well. And so that gives us a chance to sort of touch base and make sure that we still think that the benefits of this medication outweigh the risks. And two, as health evolves and new information is always coming in, is there something that's changed in their family's history where, someone had a medical problem that might be genetic, and do we need to be thinking about that? And so I would say that would be sort of a classic indication. The other is that if an adolescent chooses to become sexually active, recommendations across the board are that they be screened for the most common sexually transmitted infections at least annually, because the population from 15 to 25 has the greatest incidence and prevalence of particularly chlamydia.
Is that the toughest part to navigate when dealing with a patient who maybe isn't forthcoming to their parents? Do you get adolescents coming in here on their own without parental supervision? Is that even possible?
So ultimately, I don't have any restrictions for patients coming in if they've already established care with me. If they want to come to follow-up appointments, maybe they're 16 or 17 and they're driving, and they want to come to follow-up appointments, I don't have any problem with that, because by then they're pretty good historians and they know what's going on. But one issue is that of payment. So if you have Medicaid, for example, there's no explanation of benefits that goes home, and so it's pretty easy to come to the doctor really by yourself, and especially if you're already established care with me. Mm-hmm. Whereas if you have private insurance, then an explanation of benefits goes home. So typically a parent will find out that you went to the doctor, and the degree to which it's detailed in the explanation of benefits varies by insurer. Mm-hmm. So those are the things I usually have to counsel the adolescent patient about, is that, the EOB is going to go home, and I don't know what's going to be contained in it. And I also can't speak to their deductible and what kind of payment may be needed. And so those kinds of issues definitely arise.
Have you had cases where angry parents have come to the office, or does it never quite make it to you?
Rarely. It's pretty rare. And usually it's because they don't want to pay for the care that they feel that they didn't consent to. But typically, while trying to maintain patient confidentiality, as much as I can explain that no testing, was done that isn't recommended by their insurer. The American College of Obstetrics and Gynecology, the American Academy of Pediatrics, Centers for Disease Control. I mean, everyone agrees that this kind of screening should take place. Then it's usually ultimately, settled, I guess. But very rarely someone's pretty angry because some of those the testing is not inexpensive, and if you have in particular a high deductible insurance plan, then you're paying for all of it until you've met your deductible.
Yeah. When you're dealing with unique cases, like you said, what are some of the things that are unique when it comes to children and adolescents when dealing with gynecology that we're seeing here where you wouldn't necessarily see at an adult hospital or with adult patients? And then the second part of that question is, what kind of age range of children are you seeing, and is it across the board from the youngest children to teens or even adults?
Mm-hmm. Yeah, the youngest is probably neonates. We occasionally will get a consult to the intensive care unit or the newborn nursery, or shortly after they've been discharged home. And that's usually concerns about the possibility of a congenital anomaly, or now with prenatal ultrasound being so prevalent, we'll see some infant girls who had ovarian cysts diagnosed prenatally, and then do we need to do anything about that? Should we just follow it, or what's kind of the normal course? So I would say congenital anomalies and neonatal ovarian cysts would be sort of the youngest age group. And then as girls start to get a little older, particularly when they've transitioned out of diapers and now they're toilet trained or mostly toilet trained, then we'll see quite a bit of vulvovaginal irritation. And is that sort of more common things like maybe they're not great wipers or stuff like that, or is there actually some kind of a skin condition, that sort of complaint of a red, itchy, irritated rash that doesn't seem to go away with the things they've tried? That would be a fairly common one. Also, in those younger kids, we'll see the occasional foreign body that's been caught in the vagina. The most common foreign body being toilet paper. Mm-hmm. But I have pulled my fair share of Lego swords and Barbie shoes and other things out. As they get older, then and start entering puberty, we'll see some breast concerns. There's something is hurting, or there's a sore, or things are developing asymmetrically, or maybe there's what's thought to be an early onset of a period, and then as they move towards when they do get their first period, or maybe they're 15 and they have never had a period, or it's been more than 3 years for when they started breast development, those would be sort of indications for an evaluation. And then once their period comes, is it coming too heavily, or is it too painful, or too much, too infrequently? Things that can happen to any woman of reproductive age, but when you're 11, probably needs to be thought about slightly differently than when you're 31.
My question about what a parent should do, anybody listening, is twofold. What kinds of questions, if any, should parents be asking their children if either they see something or have a feeling that it may be best to bring his or her child in for a visit? What kinds of things would you recommend the parent do in order to both address it with the child and then also to actually go about the process of bringing the child in here?
Well, I think initially, if they I guess notice something, then I think it's fair to just, my hope is that throughout their childhood they've really treated their health and their body, that part of their body is sacred from a other people don't touch you there sort of standpoint, but throughout child visits, in the pediatric realm, I mean, a genital exam is part of the routine annual visit. I think the extent to which primary care doctors really do a complete genital exam varies, and so some kids are more comfortable with that than others, but I like to think that at least with younger kids, the parents are still doing their bathing and helping them out, maybe even with wiping, and so would notice if something was an ouchie or was red or irritated. But I think it's also fair to just, to ask. I mean, if someone had a weeping, irritated eye, you would say, what happened to your eye? And if something was red and irritated or swollen on your vulva, I would hope you'd say, did something happen there? Did you fall? Or as I think about summer here and bike riding and stuff. But I would hope that would be a fair conversation. And then I think it's just a matter of, in terms of bringing them in, do they feel like it's really an emergency? Do they need to be seen right now? Do they feel like their pediatric office is equipped to do that type of exam? And I think that probably varies by practice. Maybe historically, if at your primary visits you've never had a genital exam, then maybe they're not so comfortable with that. Mm-hmm. So I would say, we'll see patients either directly because the parent Googles us and they make an appointment, or they've been seen at an urgent care or an emergency room or a primary care clinic, and then subsequently referred. So I think sort of patients enter our clinic through a variety of means. And I always, if something's concerning to a parent or to a primary clinician, then even if it turns out to be not a great, horrible thing, it's not a big deal. I mean, it is to them. So, they obviously felt it was necessary. And even if what I do is mostly reassurance, I hope that counts as treatment too.
I think it certainly does. What influenced you to pursue this area of care? Did you know at a young age that you wanted to be in this line of work, or did your interest in medicine lead you to pediatric care?
I think if anything, growing up, I probably didn't want to be a physician. Mostly,
you and me both.
Mostly because my dad was a physician. Okay. And so I think I just in theory, I just didn't want to be like my parents,
Yeah.
But at the same time, my mother's a master's degree nurse. And so the dinner table conversations were very, usually we're very medical and big words. And so you're a curious kid and you're like, what's that? What's that?
That was way different than my family's dinner talk. We probably said similar words, but we said the generic term for it.
Yeah. So I think that was probably just something that you're sort of, it's ingrained in you, right?
Yeah.
And then I excelled in math and science in high school, whereas I did fine in all my classes, but English wasn't my favorite. And so I sort of, as I got into college, I knew I was going to be pursuing something probably in math and science. And I liked architecture, and I did some research with the Agricultural Research Service near the NDSU campus, and determined that probably research and a PhD thing wasn't going to be me, because it was sitting in a room at a computer writing grants, and there was not a lot of human interaction.
Yeah.
And so ultimately I said, well, I guess maybe I'll go to medical school, because that seems like a way to use your science, but you still get to talk to people and interact with people, and it seems like a pretty good reliable job that I could support myself. And
Were your parents encouraging? Were they supportive? Did they, you do hear people, I guess you don't really hear people, but you see it often in movies and on TV that, oh, dad's a doctor, he wants me to be a doctor, or he's making me be a lawyer because he's a lawyer. Did you get any of that pressure, or was it just a welcome, hey, we support you in whatever you do? Oh,
yeah, no, they never said either way. Nobody ever said, don't do what I do. Nobody said, do what I do. Absolutely not. It was totally like, figure it out for yourself, and, we'll kind of support you. The exception being when I got into medical school in college, and then I decided to defer for a year.
Yeah.
Moved to California and volunteer with AmeriCorps Vista. They were nervous about that.
Yeah. Well, and I'm sure you got well, it'll be hard to go back, or you'll never go to school, you'll never go back. Did you get any of that during that year?
I think not so much from them, but other people definitely. Definitely.
Yeah.
There it was fabulous living in California, and I was working Monday through Friday, 9 to 5. It was definitely, I had a great deal of fun, but in the end I was like, I can't. They intentionally have you live at the poverty level.
Yeah. Where in California did you live?
Sacramento.
Okay. That's Northern California, right? Yeah. I have a brother near San Diego, and it's been 10 years since I've been out there. I don't know why it's been that long, but it's a sweet place there. Except when they run out of water. I don't want to be anywhere near there.
Right. Yeah. No, I think there was maybe a little bit of that, which they never voiced to me. But certainly, my friends and stuff would be like, you're never coming back. You're having too much fun.
I got that a lot. I took a year off between high school and college, and it's because I didn't know quite what I wanted to do, and I didn't want to waste a year of school trying to figure it out. So I worked full time at a sporting goods store that my dad ran, and I learned quickly that I wanted to be a student, and I pursued writing and journalism, and ended up doing that. I got in for 4 years, graduated, done, worked in newspapers for 10. But we're not here to talk about me. So, but I did get it for that year where people said, "Oh, you'll never." And I think it's just a thing people say.
Yeah.
It's that standard line. And I never lost a desire to go to school. I just didn't know what I wanted to do at the time, so I wanted that year to think, and it helped. I think it really helped.
I just said, I told myself, once I get into medical school, and then you go from there, and you're never getting out. That's what you're doing. Yeah. That's who you are, and that's your identity. And so I thought, for this 1 year, I'll just move to a different part of the country and do something different.
And how do you feel about the title of doctor? Because it carries so much with it, and I think, and again, you can tell me if I'm wrong because you are a doctor. I think some people are, it's doctor, and then there are other like, oh yeah, I'm a doctor, but it's not. It doesn't define who I am. Or how do you feel about it?
Yeah, it's interesting because for a really long time after I achieved that title, Dr. Miller was my dad. It wasn't me.
Yeah.
And I think for me too, in residency, I trained out in Oregon. People are pretty relaxed out there, and they, within my training program, we referred to everyone by their first name, even our attendings. For the most part, were no, call me Catherine. So we didn't use that title very much.
Yeah.
And so it wasn't, and then even as a trainee, as a fellow, most people aren't really referring to you like that. So it wasn't really until I came here to Minnesota, when it's mostly when I hear other people talking about me, like the clinic assistants. Okay, Dr. Miller will be in shortly. I'm like, okay, that's me. So I definitely don't think it defines me because although I identify with it, it's not my end all be all. I mean, I like to think that I'm also a wife. I'm also a daughter. I also am a mother to a furry child.
Yeah.
I guess I'm a runner, I'm a biker, I have other ways of identifying.
Yeah, and that's something I run into here. Sometimes, no matter how much I've worked with a particular physician, I still feel more comfortable addressing them as doctor. No matter how many times I run into my 6th grade teacher, he will always be Mr. Schmidt. He'll never be John. And I feel that way sometimes with some doctors here. Then there are other doctors here who it's Gigi. Yeah. It's not Dr. Chawla, it's Gigi. So I think it's almost a case-by-case basis how people prefer to be addressed, or there are others where I'll work with them and you're Dr. Miller, and then who knows, maybe after today you'll be Rachel. Yeah. I don't know. It depends on if you yell at me if I call you Rachel. So we'll see. Yeah,
I'm not much of a yeller, but when I first moved here and I was trying to learn a lot of people's names, I had to limit myself to I'm either going to remember their first name or their last name, and if I'm going to be talking about them to patients, and I need to call them by their last name. So when I came, I learned everybody by Dr. Rusted, I always their last name. And so now I have to, it's hard. That's what I go with. Even if they've said, call me this, I'm like, but when I came here, I only learned your last name. So I have to, just what rolls off the tongue.
Yeah. So. And just Rusted by itself, or Preeb.
Yeah.
A little different. Right. So people locally who are listening, how can they find you and Dr. Preeb? We have 4 locations where you see patients, and that's Minneapolis, St. Paul, Minnetonka, and Woodbury.
Correct.
So how would they go about, when are you at a specific location?
Yep. Well, my schedule is going to sound a little bizarre. So every Monday morning, I'm in Minneapolis. Every Wednesday all day, I'm in St. Paul. Every Friday morning, I'm in Minneapolis. The first and third Monday afternoons of the month, I'm in Minnetonka. The second, fourth, and fifth Tuesday afternoons of the month, I'm in Minneapolis.
Holy cow.
The first, third, and fifth Thursday afternoons, I do a combined clinic with our hematologist in the hematology clinic for young women with bleeding and clotting disorders. And then the second and fourth Thursday afternoons, I'm in my general clinic in Minneapolis. So that's...
I don't know how you know where you have to be. Do you wake up some days thinking, okay, where do I need to be today? Or do you sort that out the night before?
No, I it's now been my pattern for so long, but I do sometimes have to, I wake up on or go to bed on Sunday night and have to review the week in terms of, sometimes it's the first Thursday, but it's the second Monday in the same week. So that's where I have to I just lay out where I'm going to be that week. And
okay. And people, they just call, and I know we'll provide information on childrensmn.org. With this post, we'll give people the path to finding you and finding Dr. Preeb and all the information about our program. But is it best to call? How do they go about it?
Yeah, we have a scheduling phone number, 651-220-5999. And that's the number for scheduling appointments. If there's a physician who wants to speak with myself or Dr. Preeb directly, that's there's an option for a clinician to clinician consult there. And then I think our website on the childrensmn.org, I don't know if it's /services, gynecology, something like that, also has a fair amount of information on different topics, conditions that we see. And so that can be, I think, at least a good initial introduction.
Okay. And what are some, before we go today, what are some of the topics, because you do cover such a wide variety of conditions and I can't think of another word to call it, but
Mhm.
you see people for a variety of reasons. What are the reasons, or
Yeah.
many of them or some of them?
Yeah. So I sort of got through kind of birth to adolescence, and then other things would be ovarian cysts or masses, or pelvic pain, and then congenital anomalies of the entire reproductive tract. So hymenal anomalies, vaginal anomalies, uterine anomalies, and those are conditions that we haven't limited to just pediatrics because sometimes they're not identified until you're a young adult. So we do see, you mentioned if we see adults, we will see reproductive age adults with congenital anomalies.
Okay. And are those patients who were here as children, or do you take in new patients who are adults?
Both.
Okay.
Yeah. So some have a syndrome that might include a heart anomaly too. So they're
Mhm.
already patients here at Children's, and then others, it's unique to their uterus or something. And so we'll take any of those, that kind of subset of conditions, no matter how old you are.
Okay. And is there anything else that you think a parent listening should know, or even a potential patient should know about our program, about you, about Dr. Priebe, or just something they should take away from this that they can use in their own lives?
Well, I think our hope, Dr. Priebe and I, our hope is that, your initial reproductive health visit, and because we're gynecologists, specifically with the gynecologist, is a pretty positive one. Hopefully it's educational. Hopefully it's, meaningful. We don't want to be that horror story that at least I hear so often from patients' mothers about their first gynecology visit. Our hope is that it's really a positive one because, their reproductive health is going to, if it's not already important to them, it's most commonly going to be. And it's such a major part of women's health and quality of life, as if it isn't as an adolescent, as they go on. So, our hope is that it's a good experience. We've got a good amount of time to spend with patients, and that it's done in an atmosphere where they're comfortable.
Well, I appreciate the time today and all the information you've been able to provide on an area that some people may not know, that Children's has pediatric gynecologists who see people for a variety of reasons, and you were able to share with us why it's different than, I guess, the norm, or what is perceived to be the norm.
Thank you.